I was a heavy posterior spine surgeon for a number of years, and it took me a little while to get around to laterals, and now I'm a big believer of it. And there were some downsides with lateral, essentially because the degree of radiation exposure can be fairly profound. I'm an MI surgeon by training, and I recognize MI surgery requires fluoroscopy, and other speakers have spoken to this. But laterals in particular for me was more so than, say, an MIST lift or MIST compression. And so I think you want to take advantage of what we have in terms of technology to make an operation easier and maybe better for you as a surgeon. And I think navigation really plays a strong role in this. And I know there's another speaker, Terrence, who's going to talk about this in depth. So this is just an abbreviated sort of talk, just focus on the lateral. And here are my disclosures. None of them are really relevant for this talk. So we've talked about the rationale for laterals ad nauseum, and there's a classic orthogonal approach, trans-psoas, and then there's oblique or pre-psoas variants. I'm not going to dwell on that at all. So the traditional technique obviously is fluoroscopic based, as we saw in the cadaver lab. Rod spoke to this as well, and it's predicated on getting good views. That's how you're safe with MIS procedures, and it's no different for the lateral approach. The problem is there's a lot of negatives of fluoroscopic guidance. It's two-dimensional and it can be misleading. And the old adage is one view is no view, and I think that's a very appropriate adage that you should go by. Sometimes an AP view can be very misleading, and a lateral view can be misleading the other way. So often multiple images are necessary, and depending on how good your radiology tech is, it may be really time-consuming getting that perfect shot and coming back to it. And so not only does that result in increased radiation exposure, it's also time-consuming. And I think radiation exposure is actually a pretty profound occupational hazard for a surgeon. Other speakers have spoken to that, so I'm not going to dwell on it, but it's a real issue. Early on in my career, I did a lot of MIS surgery, a lot of percutaneous screws, a lot of multi-levels. I'd hit that 5-minute warning on that fluoroscopy, that beep, not infrequently. And at first, it didn't bother me, but as the years went by, it bothered me more and more. And multi-level procedures can be very time-consuming. So navigation will mitigate all that. And spinal navigation early on was not probably reliable, not readily available, but it has really since changed. Spinal navigation has really advanced over the years, where you don't have to dwell on the reliability issues or the availability. I think there's no question that navigation is available at almost all medical centers now. And now we have intraoperative image acquisition devices that allow us to obtain imaging in the operating room in whatever position we want. So a lot of the fears of reliability issues and availability have since gone. And there's been a technological advancement in terms of the devices that are navigated, the software. So it's been very refined to this day. And this is all sort of resulted in the ability to use navigation for other aspects of the procedure beyond pedicle screw placement, which is what it was well known for. And so I'm going to present 3D navigated lateral. And there's a number of advantages, and I'm going to go through every step very clearly. Now we've about 6 minutes, and that's going to be, I think, more than enough. So positioning wise, I use a Jackson flat table with a bump. It's not a big bump. You can use a blanket or a gel roll. You don't even have to use a bump at all. You just have to secure the patient to the table so the patient doesn't move. That's a lot of taping, and I think that's essential. Okay, but a flat table is great for moving in and out your intraoperative image acquisition unit or the fluoroscope. Next step after prepping and draping is put your reference frame. You can put it in the ASIS, the anterior superior iliac spine, or the PSIS. It really depends on what region of the spine you're navigating and targeting. So you can do either. Here's an example in the PSIS. This is more important if you're doing L4-5, just if you need to do an oblique approach. Then we lay some sterile drapes over the patient and bring in the intraoperative image acquisition unit. And you could reliably obtain imaging of 4 levels, like L1, L5, with 1 spin. So it's not multiple spins. And with that 1 spin, you can do all 4 levels. I always get asked, like, are you concerned about inaccuracy? And I say, yes, obviously I'm concerned about it. But I found that you can do 4 levels with pretty good accuracy as long as you start like away from where the frame is. So if you're doing L1, L5, it started L1, 2, then progress more proximally to the frame. And you're going to see that there is some degree of error, maybe a couple of millimeters or so, but that's okay. You're not putting a screw in a small pedicle. You're actually putting a retractor over a fairly sizable disc. So, hello? Oh, I'm not sure you're hearing the music, but
we don't hear
not sure where
music.
that's coming from. But essentially, I think the degree of inaccuracy is definitely not to the extent that it can't be used. It's actually fairly accurate. And the key tool is this multi-use instrument. It's a neurostimulator, it's a dilator, and it's a tracking, and it navigates. It has a tracking frame on the tip. And so at the skin, so I'm not wearing any lead, and I'm not using any fluoroscopy through the majority of the case. I'll make the skin marking based on this navigated pointer at the skin with a projection. And I'm going to just be orthogonal to the disc. And the incision is made with that plan, just based on navigation, no fluoroscopy at all. Then we'll open abdominal musculature, traverse the or the psoas muscle with this navigator that is can be stimulated. And I'll anchor this navigated pointer into the disc space. And you can do this through a very small incision through a classic transpsoas approach. And then once it's anchored in disc space, it just sequentially dilate. Take the tracking frame off. And there's a host of navigated tools at this stage. So you're just dilating up and putting your retractor down. You could check your accuracy or your trajectory with the navigated pointer once the retractor is in place. And then you do your discectomy. Here's a navigated cob. You can do your contralateral release. So everything is navigated. So there's no question that you know where you are. And just a navigated trial. Here's your cage going in, and as you can see, you could accurately place the cage. And this is all navigated. This is the first fluoroscopic image that was obtained, so hardly any radiation. You could do an oblique approach or anterior psoas approach very easily. Often do that at L4-5. Same mechanism or same technique. Just everything's navigated. You can see where you're going, and this is just an example of the oblique approach. And as you can see, you can put the cage in orthogonally very well at L4-5. I have a video like I like to show you, see if it'll run. And this is just a patient, 78-year-old, a lot of medical problems. One of our residents, Mike Strong, put this together, did a great job on it. But she essentially has post-laminectomy instability and stenosis, L3-4 distribution radiculopathy. You can see the stenosis, I'm sorry, the spondylolisthesis that develops after the laminectomy. So at 3-4, so that's our target area. You see, positioner, just as I mentioned, she's obese. And even with that, you know, there's no fluoroscopy used here. I'll show you. So we planned incision based on navigation. This is a frame is in the ASIS. We're going to make a 1-inch incision here. And haven't used any fluoroscopy. This is all based on navigation. And this is a very similar technique to what Rod showed, but you know, we're not going to use fluoroscopy here. We're just splitting the abdominal musculature here, external, internal oblique. Then the third layer, and into retroperitoneal fat. And you can see this incision is not big. The finger, you know, the finger takes up the whole room. This is a very narrow retractor blade. And there's a navigated dilator. And it's just being used to traverse the psoas as a classic transpsoas procedure. And we're going to anchor it into the disc space. We'll sequentially dilate with nerve stimulation. This is directional. So we're mapping the plexus here. And then final dilator. Again, each dilator can be stimulated, and it's directional. It's just where the clip is attached. The retractor goes in. And the dilator serves as an anchor. It's centered down the disc space, so you know exactly where you are. Now you can use a navigated pointer at any stage to determine your trajectory or where you are within the disc space. But it was centered there nicely. You saw that little hole where the dilator was. And then we know that's the center of the disc space, and that's the annulus of the disc now. And we're just going to do the discectomy, which is pretty standard. So I'm going to try to move us forward since I've gone a little over now. But here's a discectomy, very standard. Everything is navigated. Here's a cob. You know, again, I haven't used any fluoroscopy at this stage. So zero radiation exposure for the surgeon. And let me just keep progressing here. And here's a navigated trowel going in. Now, whatever biologic you want to use. And then a final cage. Again, everything's navigated. So I'm not advocating that you don't use fluoroscopy, because if you think there's a problem, always use fluoroscopy. So I'm saying if everything goes smoothly and with a little experience, you'll get a feel for it. You could trust navigation to an extent, but I've sort of progressed to that point. And this is the final picture here. As you can see, fairly accurate, right in the disc space at L3-4, we have distracted a disc. Now, Dr. Chapman asked about whether we could use this in deformity, and I think you could use it in deformity quite easily. And it's very helpful for the rotational component that you see in a deformity. And essentially, with deformity cases, it's typically multi-level. And you could, like I said, you could do 4 levels with 1 spin, and you have real time savings here. Because if you have to use fluoroscopy, tilting the table, getting a right picture is very consuming over multiple levels. Here's just an example of this. 56-year-old Jehovah's Witness. For L2 to S1 laminectomies really didn't help his problem. He has a very big, actually a coronal malalignment. He has a coronal shift of about 6.5 centimeters and right-sided radiculopathy from the foraminal collapse there. He's pretty miserable, but he's a Jehovah's Witness. So an MIS procedure would be very appropriate for this. And here's his MRI and CT. So it's just foraminal stenosis, not central. He's got a good laminectomy. So I treated this with navigated laterals, MIS TLIF, and perk screws. As you can see, the lateral is very helpful in this, navigation is very helpful for the lateral approach here, just because of the rotational aspects of it. So in summary, navigated lateral is feasible and safe. Radiation reduction can be significant, and is particularly helpful in multi-level cases and deformity. Thank you.
Good stuff, Paul. Thank you so much. Great slides, also nice visuals. So let me get something straight. And anybody who knows me, and you know me, I'm a little bit slow on the uptake. So let's just go for a multi-level lumbar spine. Your referencing is off of 2 vertebrae, right? So your fiduciary markers are on 2 vertebrae. And you're going to change the alignment of the spine as you're distracting quite successfully. Do you have to re-reference the levels above them, because you're basically leaving kind of the 3 millimeter plus relative reference in a mobile spine, or a newly mobilized spine that you're changing alignment on? Or how do you handle that profound change of alignment in a multi-level case?
That's a great question. I actually get that asked all the time for multi-level cases. So the frame is in the ilium. And so if I'm doing a multi-level case, I'll start farthest away from it. So if let's say I'm doing 4 levels from L1 to L5, just as example I showed you. So I'll do the discectomy at L1, 2, put the cage in, and it does shift the spine. There's no question of that. But it's less than I originally thought. So when I first did this, I did a lot of fluoro with the navigation. I didn't really trust it very much, just because I didn't want there to be a catastrophic problem. And what I found was it wasn't as inaccurate as I thought it would be. So it would shift a couple millimeters or so, but not to the extent where you couldn't use navigation. Remember, I'm just using it as trajectory view and try to get into the disc space. The disc space, unless it's severely collapsed, there's some wiggle room, so you'll be in the region, and it'll give you enough localization that you'll be able to put the retractor down once you anchor in disc space. And then again, you could confirm with spot fluoroscopy. I'm not advocating you don't use any fluoroscopy per se. I think you'll find you'll get more comfortable with it and you'll use much less, but it's definitely doable with multi-levels with 1 spin. Now, if there's any question, you either respin it or you just use fluoroscopy. But I've been using this for three plus years now, and I found with multi-level cases, I rarely have to respin it. It is accurate enough to do the procedure.
Hey, Jens.
Sorry, yeah, go ahead.
Jim here, real quickly. We've actually been very lucky. We have most of the navigation systems, and I find it amazing that we use the Globus robot system, and it fixates on it takes its image guidance off the body pedicle references. And so if you scan these people, and I think you guys do it similarly, you'll correct their deformity with an ALIF, but then you use the pre-scoliosis CAT scan as your basis, and the accuracy to me has been amazing. And so I think what these image-guided systems do is they more base their reference points on the pedicles and the disc bases, because you got to remember, they access all their points of information, and that doesn't change. So it's, and I agree with Paul, the accuracy has been unbelievably much more than I thought it would be.
How's your soft tissue recognition? How much input do you get? Because you still have your neuromonitoring going on at the same time, right?
Right. So no, I think it's pretty accurate. You can map it's directional EMG, so you can still map where the plexus is if you want to. You know, I'm actually happy if I don't get any positive response because I know I'm safe. And in terms of soft tissue, you can also see the great vessels pretty nicely. So, you know, I'm always fearful of a vascular problem. And so I you know, particularly if you're doing ACR, you could put the pointer right in front, you know, you have an idea of where the great vessels are. I just feel a lot more safer doing that. So with 3D navigation, the trajectory views are just key. Again, I don't think it's sub-millimeter accuracy. I think after the first disc level, you're talking about 2 or 3 millimeters where you're kind of in the vicinity. But it's enough that, you know, and again, you have to have some experience with laterals. You know, if you have some experience with laterals, and then you move on to a navigated procedure, it does wonders for you. Because you have enough experience that you know your way around the block a bit. And the navigation just gives you enough that you're able to do the procedure. Now, again, if you're not certain, I would just get a spot fluoroscopy, confirm your accuracy, then move on. But you're not typically wearing lead for this. It's great. I mean, the degree of radiation exposure that you're exposed to is markedly less. And I think it's faster because for multi-level cases, just moving the fluoroscope in and out just is very time consuming.
So final question for you, and thank you for all your expertise. L4-5 for the far lateral surgeons has been kind of one of those gray zones just due to pelvic height. Has this navigation changed the ability to kind of get devices into 4-5?
Absolutely. So I shared the concern. When you're doing a classic transpsoas, depending on where the ilium is, I would look at the films all the time. And then you hem and haw where you could get it in. You can use angled instruments. But that L5 end plate, you can violate that pretty easily, just because your angle of approach often could not be orthogonal. And that's where you have the oblique surgeon saying, oh, do it oblique. But I find oblique a little bit more of a challenge sometimes in terms of trajectory. With navigation, not an issue. At the skin marking, I often go pre-psoas there because it's so easy with navigation. You just project a trajectory. And at this, you can make a relatively small skin marking and approach it like whatever angle you want that'll avoid the ilium. And then once you're in a disc space, you know, you could do your work there, and you know, I use a dual-bladed retractor. So then, once you put the cage in about a third or halfway, you could shift the handle dorsally, and you don't have to worry about navigation at that point. Half the cage is in a disc space. So even if you shift the spine at that point, it moves with the cage because half of it's already in there. So then I'm able to turn it like in the case example I showed you, where it works quite well. You just have to play around with it a little. But it does help you in that regards.
So the second of my threatened question is left versus right and lumbar scoliosis. Rod basically said he's just going from the left side. Has navigation changed your approach? Do you feel comfortable right, left, convex, concavity, etc.?
Yeah, I've done both sides, both. And if you go on the concave side, it's just one incision or maybe two. If you go on the convex side, you're making like 3 or 4 incisions typically, just because of the curve. And I think it's also a longer reach, depending on the concave or convex side. And I don't know if my screen's still up, but you know, it's just a longer reach depending on the side. If you look here, so it really depends on my feeling. I think you go either with navigation because it's so easy to figure out which is going to be easier for you. So this is going to be a longer reach here, versus on the and this is the concave side versus the convex side. There's a short reach, and the disc is much bigger because it's not asymmetrically collapsed. So it depends on your viewpoint of what you're trying to accomplish. If you're trying to get a disc space easier, and with navigation, go on the convex side. On the concave side, you're going to have to use an osteotome, and that's going to require a little bit of spot fluoroscopy once you get down there. Because I don't trust navigation perfectly. It could be off a millimeter too, and if you're using a sharp instrument, you should confirm it before you pound it in. So I think it's just surgeon bias.
Well, a lot of experience. Appreciate your frankness, and thanks for spending your time with us.